Good day, dear colleagues. I'm happy to meet you today in our weekly webinars that are organized by Crystal Vision Eye Clinics by Professor Igor Aznauran. And today, the topic of our talk will be refractive surgery. Different advances that we have in last 5 years in refractive surgery, and I think that we will continue this topic in future by their implantation of intraocular lenses in also topics that are considered complications of refractive surgery. Today we will talk only about things that are connected with different techniques, their advantages and disadvantages. And we will try to find something new and understand how to use them in our routine and what patients are the best patients for each technique. So I will share my presentation. So let me start my talk about advancements in refractive surgery, a 5-year review. So refractive surgery has evolved significantly over the past 5 years, and this presentation reviews the latest advancements, techniques, outcomes that have transformed patients' care. Understanding these developments is crucial for eye care professionals and patients alike. Recent advancements in technology have enhanced surgical precision and patient outcomes. Innovations such as wavefront-guided systems and femtosecond lasers have improved the safety and effectiveness of procedures. Before moving on to a review of the literature, I would like to return a little to the history and basics of refractive surgery. For the first time in 1869, Snellen, the same doctor who created tables for checking visual acuity, he described surgical operations to correct astigmatism using corneal incisions. Then a scientist from the USA proposed removing part of the corneal tissue in its thickness to eliminate myopia. In 1953, Tsutomu Sato from Japan developed posterior radial keratotomy. Because these techniques gave a large number of complications, they were soon forced to abandon it. Using their idea, Japanese scientists, in 1973, Sviatoslav Fedorov developed anterior radial keratotomy, and it was one of their most important steps in refractive surgery in past century. So the further development of refractive surgery was marked by the advent of excimer lasers. In 1970, a group of Russian scientists invented the first excimer laser, where the source of radiation is excited particles, excimers, from the English excited dimmer. Anticipating the role of laser in eye surgery, Professor Sviatoslav Fedorov already in 1974 created a laser group under the leadership of the talented young scientist Semyonov, which in 1918 was transformed into the All-Russian Laser Ophthalmological Center. The crowning achievement of the laser trend in refractive eye surgery was development of the photorefractive keratectomy, PRK. And this method has been used in world practice since 1983 and in Russian practice since 1984. So PRK allowed world ophthalmology to take a huge step forward in the tissue of emmetropia correction. And this technique continues to develop to this day, opening up more and more new horizons. So from the starting of the refractive surgery era and after the approval of FDA Food and Drug Administration for adult population, we have 30 years. And during these 30 years, 50 million people undergone refractive surgery, and most of them has very good results of that. Traditionally, refractive surgery may be considered as two major subdisciplines, which can be applied jointly in some cases to correct complex refractive errors. It is keratorefractive or intraocular IOL-based surgery. So keratorefractive surgery involves altering the corneal surface shape, while with IOL-based surgery, an IOL implant is added to the optical elements. And corneal topography provides an assessment of corneal surface shape, while wavefront analysis provides an assessment of image formation by the entire eye's optical system. Conventionally, these investigations have been routinely used in preoperative evaluation for refractive surgery. Today, for sure, we will talk about corneal refractive surgeries. About IOL surgeries, we will talk later during our webinars. So corneal topography is one of the most important diagnostics that we refractive surgeons usually do in routine examination of the patients before surgery. And the corneal visualization tonometer, Corvis Oculus, that use high-speed Scheimpflug camera that visualizes corneal change during deformation to produce various parameters. Also, the gold standard of keratotopography, the Pentacam, can show us some subclinical keratoconus among eyes clinically deemed to have normal topography. That's why it is one of the most important diagnostic things that we can have in our examination. Also, we start to use OCT platforms and OCT platforms that can give us in one picture and topography and tomography and anterior segment metrics, axial length measurements, and also IOL calculations. Also, OCT we can use in patients who had undergone refractive surgery for understanding what is their visualization of their flap, for example, what is their thickness of it, and then we can understand if there is some hazes, and even we can measure these hazes using OCT topography. So artificial intelligence is everywhere now in our lives, and for sure ophthalmology is one of the spheres of medicine where artificial intelligence is very started to be very developed. And also artificial intelligence we can use in refractive surgery, and there are deep learning machines that can, for example, by understanding different parameters of the eye, of the length eye, of the parameters of the keratotopography, they can show us this or that percentage of, for example, keratoconus. And if it is normal, for example, we don't need to do any other examinations. But if it is some subclinical forms, or if artificial intelligence say that there can be some problems, then these pictures can be given to doctors for more deeper understanding and examination for making more deep examinations to these patients. And deep learning using the wall image of, for example, 6 corneal color-coded maps, anterior elevation, anterior curvature, posterior elevation, posterior curvature, total refractive power, and pachymetry map with the anterior segment OCT has also performed to determine the diagnostic accuracy or the grade of keratoconus. For example, Atlas by Carl Zeiss give us the percentage of the keratoconus in the patient, and we can use this information for evaluation of other information. When we talk about different techniques in ophthalmological refractive surgery, we should start from surface ablation techniques, and it is consists from photorefractive keratectomy, PRK, that involves epithelial removal, or laser epithelial keratomylosis, LASIK, where 20% alcohol is used to displace the corneal epithelium. Unlike LASIK, PRK doesn't require corneal flap, making it a suitable option for patients with thin corneas. And recent advancement in laser technology have made PRK more precise, reducing the risk of haze and improving visual outcomes. The use of alcohol during LASIK results in apoptosis and necrosis for a larger number of anterior keratocytes, and rabbit eyes that had epithelial scrape PRK had greater keratocite density in the anterior stroma at 24 hours after surgery than eyes that had 50% ethanol-assisted epithelium scrape during PRK. It is from authors Helena and et al. That this information, that this article was published in 1997. And since keratocite-produced EBM components contribute to EBM regeneration. But now we understand that ethanol-assisted removal of the epithelium can increase PRK-induced stromal fibrosis, late haze, including breakthrough haze, where fibrosis occurred despite treatment with mitomycin C after PRK. However, for example, 2 clinical studies found no difference between ethanol-assisted and mechanical scrape epithelial removal. I should say, for example, from our experience, we usually use LASIK, so alcohol-assisted PRK, when we need to do their surgeries in thin corneas, or for example, when we do refractive surgery in hyperopic eyes. So more recently, excimer laser ablation has been used to remove the corneal epithelium directly. So it means that transepithelial PRK. One advantage of transepithelial PRK is that the epithelial layer removal and excimer is performed at the same time. Although most reports suggest that healing time and visual outcomes results do not vary greatly amongst the various techniques of epithelial removal. That's why, so we can for sure use transepithelial PRK, but to say that there is some difference between results of the visual acuity, we cannot say this information. So what consists of mitomycin C? We understand that scarring and haze can occur from the healing response in the Bowman's lower and anterior corneal stroma. And low-dose topical mitomycin C, usually 0.02, 0.04%, is usually applied after excimer laser to reduce haze formation. But nonetheless, patients may still experience more discomfort after surface ablation compared with LASIK due to the healing of the epithelium. There was discussions on how long we need to use mitomycin C, what is the percentage need to be from the mitomycin C, and So the later study suggested that 0.002% mitomycin C might be as effective as 0.02 percentage mitomycin C. But clinical studies in human found that this concentration resulted in more clinically significant late haze. So better use 0.02%. And about the time of their application of mitomycin C, so studies show that 12 seconds had equal efficiency in preventing haze after PRK to treatments for 60 or 120 seconds. But for example, we in our usual routine surgeries, we use 30 seconds of application of mitomycin C. So what concerns of LASIK? LASIK or laser-assisted in situ keratomylosis has been around for decades, but recent innovations have made it even more effective. And one major development is the use of femtosecond lasers to create the corneal flap, replacing the microkeratome blade. I should say that if you use good microkeratomes and know how it works, for me, there is no big difference between LASIK and femtoLASIK. Because if, for example, you are using, I can say from my practice, Moria microkeratome, their flaps and the thickness of flaps is very predictable, and you can use as thin, so thick flaps for different values of myopia. That can also be very helpful in patients with different with different stages of myopia. So there was a review of LASIK outcomes that was done by Sandoval et al. In 2016. And there were analyzed more than 67,000 eyes, and visual acuity was, after correction, 0.5 or better in 99.5% of eyes. And spherical equivalent refraction was within plus minus 1 diopter of target in 98.6% of eyes. And loss of 2 or more lines of corrected distance visual acuity was 0.61%. So only 1.2% of patients were not very satisfied by their results of their surgery. So it means that if this review was made in 2016, after 2016, we have many other different interesting and very helpful innovations in refractive surgery. And it means that nowadays satisfaction of patients after the refractive surgery should be higher if we will do this research. So there were 2 very important innovations in LASIK. One of them was topography-guided LASIK, and a second one was wavefront-guided technology. They both make LASIK much more predictable and give us a chance to make customizations and to make more accurate surgeries. Wavefront-guided technology show us that creates a detailed map of the eyes and show all imperfections. Especially it was very important for the eyes that was after, for example, trauma, or it was the second step of their refractive surgery, or this eye was operated before. It gives us a chance to take into account all imperfections and make wavefront guided procedures for improving visual acuity and reduce issues like halos and glare. So another very important part of the development of refractive surgery was SMILE, a minimal invasive technique that has gained traction in recent years, and it offers a faster recovery time and less discomfort post-surgery. Femtosecond lasers shows us and allow to make ultra-precise cuts and reshaping of the corneas. And the result is a more accurate procedure with a reduced risk of complications and faster recovery time. So also what I want to say about SMILE, one comment that SMILE brings two main advantages over LASIK: faster dry eye symptom recovery and better spherical aberration control. And both of these advantages from the minimal invasive pocket incision that results in maximal retention of anterior corneal innervation, as well as structural integrity. But also we need to understand that there are some disadvantages of SMILE, and we cannot use it in very high myopia patients, and usually it is very predictable for treating moderate myopia and modest levels of astigmatism. So femtosecond lasers are now commonly used in various refractive surgeries, and we understand that also what is the next step is to correct a presbyopia, because patients after 14 who come to the consultations and say, why you cannot help us? It is there a pool of patients who really don't want to wear glasses, and they need also some techniques for making the quality of their lives much more better. So if we are talking about corneal refractive surgeries, we understand that the majority of corneal multifocal treatment essentially creates a central island to provide near vision, while a hybrid combination of multifocality with some induced anisometropia may have improved safety. However, some studies using this hybrid protocol report an unacceptable rate of loss of two lines of visual acuity. So also there is a laser blended vision that is based on nonlinear change in sphericity, and it is tolerated by more than 95% of patients, compared with monovision, which is tolerated by only between 59 and 67% of patients. Because it is not a multifocal treatment, laser blended vision has also been shown to provide good distance, intermediate, and near vision without the increased risk for losing lines or of corrected visual acuity. So what also we should talk about when we are talking about refractive surgery in the last 5 years, it is a refractive surgery in children, corneal refractive surgery in children. And the head of Crystal Vision Eye Clinics, Professor Igor Aznauran, and a group of authors back in start of new century 2000 published works on refractive surgery in children, both for the treatment of amblyopia and for the purpose of eliminating the accommodative component of strabismus. And in 2001, a patent was received for the use refractive surgery in the treatment of amblyopia. Also, there is a publication on laser correction using PRK dating back to 1995 by Dr. Daljit Singh, and he talks about his experience in treating kids aged 10 to 15 years, and in all patients it was possible to reduce refractive error and increase visual acuity. One of the patients after laser correction underwent pleoptic treatment of amblyopia, and as a result of which was a significant increase in visual acuity. Also, there is articles from doctors from Canada, William Assel and Peter Huang, claim to have performed the first PRK on a pediatric patient back in 1998. In 2002, colleagues published a paper in which they talk about the experience of treating children with emmetropia using laser visor correction. And they treated 40 eyes in 27 patients, and all patients underwent laser correction under general anesthesia. According to average indicators, visual acuity increased from 0.25 to 0.5 during the first year of observation. Myopic spherical equivalent decreased from minus 10.68 to minus 1.37 diopters, and hazes developed in 60 patients, which is 40% of all patients, of which 2 patients required additional correction, and as a result of which the hazes became smaller. Unfortunately, there is no information about the age of children anywhere. Later, same authors will publish a number of works devoted to refractive surgery for kids, including LASIK, and in all their publications, they talk about excellent treatment results. In 2005, doctors from Georgia, under the leadership of Professor Mirab Dvali, published a paper in which they shared the experience of performing LASIK refractive surgery in kids with hyperopia. Our colleagues also pursued the goal of not only treating amblyopia, but also correcting the accommodative component of strabismus. I should say that in Crystal Vision Eye Clinics in Moscow, we use refractive surgery in kids with accommodative strabismus for treating their strabismus, and it is the first step. So we don't do their refractive surgery after we will do the surgery on muscles. Refractive surgery is the first step, and it is the technique that was investigated by our head, Professor Igor Aznorian, and is used for all kids with accommodative strabismus. So by analyzing the available literature, we see that doctors around the world are looking for ways to improve the effectiveness of treatment for amblyopia in kids in order to improve the quality of life of our young patients. And very important is to create a very interesting social atmosphere, kind social atmosphere that will give them a chance to feel themselves very comfortable in the world. And so what concerns patient selection criteria, it is also a very interesting topic for discussion, because sometimes patients come to us and ask, do I need to make a refractive surgery? Usually I'm saying that if you want, you need to do. If you don't want, you don't need to do, because it is more in adults cosmetic surgery, and a patient need to understand for what he is doing that. He need to have lack of quality of life with glasses or soft contact lenses, and it will give a chance him to do surgery and feel himself much more better after it. And there is many other future directions in refractive surgery, and it is not only about artificial intelligence and development of new refractive machines, but it is also, for example, development of much more accurate and predictable refractive surgery in hyperopia and in high astigmatism and in high hyperopia and also myopia. And I think that in next 10, 20 years, it will be the most important fields where a refractive surgery will be developed. So in conclusion, I should say that refractive surgery is one of the most developed part of ophthalmology, and there is many techniques, companies, technologies that are coming to this sphere of ophthalmological life, making our work much more accurate and better for our patients. Thank you so much for being today with us. If there will be any questions, I will be happy to answer them. And also you can connect with me directly. There is my phone number for any questions, especially if you want to collaborate, and my email. I should say that till September 10th, Professor Igor Aznavrian is having consultations in Crystal Vision Clinic in Bahrain. So if you want to come and meet him, see our ophthalmological service, we will be happy to meet you there. Thank you so much, and have a good day.